Hello everyone, this is my last video session on Retina and Neurophthalmology. It's going to be a short quick one, so I hope you'll be able to keep up with the pace. Now let's look at how a normal retina and optic nerve looks like. This is a normal retinal picture in which you see the optic nerve here. This is known as the optic disc, and this is the area from where we see what we call as the macular area, in the center of which we have the fovea, where exactly our vision is formed. We have blood vessels which are arranged in form of four arcades. We have the superior temporal arcade, we have the inferior temporal arcade, we have the superior nasal arcade, and inferior nasal arcade. Now, comparing your arteries and veins, you'll find that you're going to find arteries which are smaller in color, smaller in size, and bright red in color, while you're going to find the veins as little more bigger in size and much more darker in cover. The ratio of arteriovenous size ratio is what we call 2:3, which of course reduces in hypertensive retinopathy, in which the arteries become much more narrower and veins remain of the same size. So when you're talking about the optic disc, we also have to look at the size of the optic disc, the shape of the optic disc. Normally it is oval in shape, and very importantly you have to look at the margins of the optic disc. The normal margins of the optic disc are well defined, they are sharp in contrast with the retina here, and in the center of the optic disc you have a cup shaped depression through which the vessels come out. It's very important to look at the size of the optic cup to the size of the disc, because it changes in a disease what we call as glaucoma, which I will see in our subsequent slides. The normal optic disc is pinkish yellowish in color because it has vasculature, which is of course in some cases when there's a damage to the optic nerve, you'll find this to be changed. So that's how a normal retina and fundus looks like. So let me go to the first slide here, in which we're looking to look at the glaucoma. So this was the optic disc, as I explained earlier, and in the center you have an optic cup, and the size of the optic cup as compared to the size of the optic disc is what we call as the cup disc ratio. If you look at this size, it's around 30 to 40% of the size of the optic disc. So the cup disc ratio in this case is approximately 0.3 to 0.4. As compared to this picture here, you find this optic disc is this one, and the optic cup is here, and size of the optic cup to the size of the optic disc is approximately 80%, which is quite high. This gives a diagnosis that this patient could have glaucoma, and you need to do additional investigations in form of intraocular pressure measurement. You need to do what we call visual field analysis, in which you want to have typical visual field defects in form of arthroscotomas, and in the advanced stages a tunnel vision. And you may also need to do investigation like gonoscopy to find out if the antechamber is interior angle of the antechamber is open or closed. And there's another new investigation what we call as optical coherence tomography. We can also let us know the thickness of retina, which of course gets damaged in diseases like glaucoma. So please remember, increased optic disc is quite important finding, and the patient needs to be investigated for a disease called glaucoma. Coming to another picture in which you want to look at your optic disc margins. I have a patient here with 35-year-old patient presenting with recent onset hazy vision in the right eye, and you find that optic disc margins are quite blurred, as compared to another patient who is presenting to you with normal vision and occasional headaches and vomiting, and you find the optic disc margins also blurred and the optic disc looks elevated. Can you pick up a difference between these two? Yes, you are correct. The picture on the right side, in which the patient is presenting with headaches and vomiting, and very importantly has a normal central vision, this patient is having what we call as a papilledema. And this papilledema could be due to different causes. One of the causes could be because of raised intracranial pressure due to an intracranial tumor or meningitis, encephalitis, anything here, subdural hematoma as well. But very importantly, in papilledema, as you understand, the patient vision is normal. And if you look at the condition on the left side, this patient is having an optic neuritis. Very specifically, the patient has a papillitis in which the disc margins are hazy, but very importantly, the patient has a hazy vision. And if you look at the pupils here, the pupils, you're going to have a relative afferent pupil defect. You're also going to have a color desaturations, which are a typical findings in optic neuritis. So remember to differentiate an optic neuritis with and papilloma. In optic neuritis, you're going to have a blurred vision, very important decrease in vision. You're going to have relative afferent pupil effect. You're going to have a color desaturation as compared to papilloma, which you're going to have a normal central vision initially, following which you can have patient symptoms like headache and vomiting, but the patient vision is going to be normal, pupils are going to be normal in the initial stages, and even the color desaturation is not going to happen in the early stages till such time it becomes very late and patient develops an optic atrophy. Now, most of the important cause of optic neuritis is multiple sclerosis, and this patient needs a treatment in acute stage in form of intravenous methylprednisolone, which needs to be given 1 gram per day for 3 days, following which you need to give 1 milligram per kg body weight for the next 11 days. This is as per the optic neuritis treatment trial recommended guidelines. For papilloma, the treatment is the cause. You have to look at what's the reason and then treat them accordingly. Now, if you look at this picture here, I was talking to you about the color of the optic disc is very important. If you look at the optic disc here, the optic disc looks totally pale in both the slides. This is what we call as an optic atrophy. This could be of various causes. Could be primary optic atrophy, in which the child is born with optic atrophy or a dead optic nerve, or it could be due to other causes like vascular, or even glaucoma is another kind of glaucomatous optic atrophy. Now let's come to the important condition of diabetic retinopathy. You're going to have many auscultations, or even at the exams you could have it, in which there are many series of changes which takes place in a patient who have diabetes. Now, the findings typically include hemorrhages, which could be dot and blot like a blot, or there could be flame-shaped hemorrhages, also leading to a swelling of the macular area, what we call as a macular edema, which is very nicely shown here. These are what we call as bright yellow spots, which are known as hard exudates. These are basically lipoproteins which get leaked out from the blood vessels, and if they are in the macular area, these would actually cause you quite a disturbance of the vision, because a lot of edema is present in this area where your central vision is formed, and the patient is going to come to you with a very hazy or a blurred vision. But remember, till in these two slides, there are no new vessels. These are not new vessels. These are only hemorrhages here. So there are no new vessels in the optic disc here. So till this stage is still a non-proliferative diabetic retinopathy. Very specifically, this stage in which you have the hard exudates is known as diabetic maculopathy. Diabetic maculopathy if we have a hard exudates in the macular area. But as compared to another slide here, same. We have a lot of hard exudates in the macular area, lot of swelling, couple of dot hemorrhages. Still, this patient has a non-proliferative diabetic retinopathy with a diabetic maculopathy because it's involved in the macular area. But if you look at this picture here, you see these fan-shaped areas. Now, these fan-shaped areas are the areas of new vessels. These are the areas of new vessels. This is just like a C-fan-shaped bed, and these are the risk stage is known as proliferative diabetic retinopathy, and this patient is at risk of developing a bleeding inside the eye. A very common finding. A sudden onset patient comes to with blurred vision, starts seeing some floaters, and most important diagnosis, different diagnosis in this case would be a vitreous hemorrhage. Another slide which is very common is a patient with a what we call age-related macular degeneration. This patient will present to you with distorted vision, central vision, and we look at the fundus, you're going to see some bleeding or some abnormal membrane in the macular area. This is what we call as age-related macular degeneration, very common, important cause of poor vision elderly, especially in the Europeans and Americans. This on the left slide is a normal fundus, and this is a normal this is a test which we do to pick up a scotoma. This is known as Amsler's grid, and patient is instructed to look in the small dot in the center and is to see whether all these lines are normal and parallel. A normal patient should be able to see all the lines, and all of them lines should be straight. But patient who's having macular disease, something like a macular degeneration, would find that distorted lines, curvy lines, curved lines, and this is an important finding which we need to detect, and the patient needs to be treated aggressively. So this test is known as Amsler's grid charting. Very important test which you do for the macular diseases. Now, very sorry about this slide here. If you look at the slide here, you are finding that there is This patient presented to you with sudden onset vision loss. And if you look at this retina here, this retina is whole pale. There is total loss of arterial blood supply. This is very typical of what we call a central retinal artery occlusion. As compared to the picture on the right side here, where you find that the optic disc is blurred and there's all scattered hemorrhages all across the fundus. This is typical of what we call a central retinal vein occlusion. See the difference between the vein occlusion and artery occlusion? Artery occlusion is going to give you pale retina with no hemorrhages. The whole retina is going to be pale, and you're going to find what we call a cherry red spot because of the edema in the retina here. The normal parietal vasculature shines through, and this is what we call as a cherry red spot, typical of central retinal artery occlusion. As compared to central vein occlusion, which you're going to find scattered hemorrhages all across the fundus, lot of soft exudates here. And one of the risk factors of central vein occlusion is hypertension. Again, I repeat, one of the important causes of central vein occlusion risk factors is hypertension, while in central artery occlusion, one of the important risk factors is embolus, which may be from the heart or from the anywhere in the body, which causes occlusion of the central retinal artery, causing a central retinal vision loss. This patient is a myopic patient who presents to with flashes of light and seeing some curtain in field of our vision. This is what we call as a retinal detachment, very commonly seen in patients who are myopic, having a high number, and it's important to screen these patients for any tear in the retina, which could actually it could be a precursor of a big retinal detachment. This great thing which you see here is the retina, which has got detached from the underlying structures. Coming to the last slide of neuro-ophthalmology, this is one patient who is presenting with drooping of the left upper lid, with deviation of the one eye towards to the outside, what we call as exotropia. This patient is having what we call as a what could the patient be having? Exotropic ptosis. If I check the ocular movements are restricted in elevation, adduction, depression. Only ocular muscle which was working was the lateral rectus. So you're correct, this patient is having what we call as a third nerve palsy, in which the patient will present to you with drooping of the left upper lid because of the involvement of the levator palpebris superioris, and the patient is going to have diplopia because this is a paralytic squint. You're also going to have deviation of the eyes because the superior rectus, middle rectus, inferior rectus, and inferior oblique, all of them are paralyzed. The lateral rectus will pull the eye outwards, causing a significant amount of ocular deviation. The important question which is asked in this oculomotor nerve palsy is important for you to differentiate a medical cause from a surgical cause of nerve palsy. The medical cause I would mean that is most commonly diabetes, and the surgical cause which we commonly say is an aneurysm. A perianeurysm which is present in the between posterior communicating artery is an important cause of nerve palsy. So how you differentiate a medical cause from a surgical cause of nerve palsy is that if you evaluate the pupils in cases of a surgical cause like an aneurysm will cause the pupil to dilate. While a medical cause like in diabetes or hypertension, if the cause is diabetes and hypertension, you'll find that the pupils are normal. So dilated pupil or pupil involvement in third nerve palsy is highly significant of a surgical cause or an aneurysm of the patient. So it's very important if the patient is coming with third nerve palsy, please evaluate the pupils very carefully, because if it is a young patient with a headache with a pupil involving third nerve palsy, it's very important to rule out aneurysm, send the patient for an MRI angiography scan to pick up aneurysm and then treat it accordingly, because it can bleed and cause more other complications. But if it is a medical cause like diabetes and hypertension, the pupils are normal, patient has a known cause of diabetes, just give reassurance, and because these renal palsies because of medical cause are self-limiting and self-resolving, and patient becomes better very soon. So that's all about it. I hope you would find these sessions useful, and please appreciate your feedback so that we can improve on these sessions. Thank you so much. Bye-bye.